On behalf of the American Heart Association, I would like to welcome you to this session, Components of HCM Care, Implications of Genetics Across the Continuum. Throughout this session, you will have the opportunity to submit text questions for our speakers using the questions feature on your control panel. You may send in your questions at any time, and we will review them during our Q&A at the end of the presentation as time allows. To access live closed captions, please click on the closed caption button found on your screen. As a reminder, all sessions will be recorded and available in the coming weeks. It is my pleasure to welcome our speakers for today's session. Courtney Hannum is a licensed genetic counselor in Cincinnati, Ohio, and she specializes in hereditary cardiovascular disease and oncology. Dr. Bani M. Azari is an assistant professor of cardiology at the Donald and Barbara Zucker School of Medicine at Hofstra, Northwell, and is the founding medical director of the Program for Cardiac Genetics, Genomics, and Precision Medicine at Northwell Health. As a reminder, full speaker bios can be found in the event lobby. Dr. Azari, the floor is yours.
Thank you and good afternoon. We have no disclosures. And today we're going to be talking about components of HCM care and the implications of genetics across the continuum. Starting off, the genetic etiology of hypertrophic cardiomyopathy arises from autosomal dominant mutations in the sarcomeric and sarcomere-related genes. And these are the genes that are involved in the heart muscle cell squeezing. Now, about half of our patients who will have a positive genetic finding will have a mutation or variant in the myosin binding protein C3 or myosin heavy chain 7 genes. However, because we still cannot identify a genetic cause in about half of our patients, there are still genes that we have yet to identify as being associated with hypertrophic cardiomyopathy. We also know that in families with an identified genetic cause for HCM, not all family members will have the same pattern of HCM. We understand that patients with the reverse curve phenotype are more likely to have an identified genetic cause than patients with the isolated sigmoidal hypertrophic cardiomyopathy. But in a family with the same genetic finding, it is possible for one individual to have this feature on echo, another to have this feature, and another to even have this feature on cardiac imaging. Now, genetic testing is recommended for all patients with hypertrophic cardiomyopathy, but genetic findings in HCM do not determine risk. Rather, they help figure out who should be monitored for risks. And this is the risk for ventricular arrhythmias. And those are dependent on clinical findings. And those clinical findings include prior events, family history of sudden death, wall thickness on cardiac imaging, unexplained syncope, as well as short runs of ventricular tachycardia. And this is because carrying a genetic variant for HCM does not mean that you will develop the clinical condition. We know it is the combination of genetics along with hereditary environmental factors that causes the wall thickness to develop. But if genetics does not dictate risk, why is genetic testing so important? Well, it helps us determine who needs to be monitored for risks, particularly in family members. In patients with clinical hypertrophic cardiomyopathy that you see on cardiac imaging, it is clear that they should be monitored regularly. But when you have individuals who have a known genetic variant that runs in their families, genetic testing can be used to determine which individuals in that family that need to have regular cardiac evaluations and who does not. It also helps identify individuals who should work on reducing modifiable risk factors. Now, we don't know all the environmental risk factors that are associated with hypertrophic cardiomyopathy, but we do know that there are modifiable risk factors, including hypertension, obesity, kidney disease, microvascular coronary artery disease, and cocaine abuse are independently associated with hypertrophic cardiomyopathy. So in family members who are found to have or carry the hypertrophic cardiomyopathy disease-causing genetic variant, but don't yet have hypertrophic cardiomyopathy clinically on cardiac imaging, I recommend that they lead a heart-healthy diet, a lifestyle with heart-healthy diets, moderate regular exercise to avoid obesity, sleep apnea, hypertension, and to aggressively treat hypertension in these individuals, all with the hope that this may reduce or delay the onset of them developing the clinical hypertrophic cardiomyopathy. And this is just one of the many reasons why genetic testing is important.
Thank you, Dr. Azari, for explaining the genetic etiology of HCM. And now that we know how genetics plays a role in the development of HCM, I want to focus a little bit more on the details of why genetic testing is important for both our patients and their families. So genetic testing is most helpful when we begin with someone who has a diagnosis of HCM themselves. Oftentimes, this is to help the physicians confirm a clinical diagnosis, as we've heard from some of our clinicians earlier today, because there can be similarities between HCM and other types of cardiomyopathies or arrhythmias. For example, we've seen that through genetic testing, we can at times distinguish between HCM and something like an infiltrative cardiomyopathy like amyloidosis. The correct diagnosis can be really helpful in directing management and treatment options for these people. But additionally, there are times when identifying a genetic variant can lead to a better understanding of risk. For example, a certain gene or variant might have a higher risk associated with sudden cardiac arrest, and therefore might contribute to the decision to place an ICD or to make some lifestyle modifications. But as Dr. Azari mentioned previously, genetic findings themselves do not provide the full answer. They're simply, they can and they should be included in the decision-making process. Genetic testing is also really helpful for family members. As we've mentioned, it can help us identify who within the family is also at risk, which for those who are, would help them establish routine screenings to increase the chance of diagnosing HCM at an earlier stage. And I'm actually going to skip ahead for a minute to the AHA-ACC genetic testing algorithm, just so we can walk through how genetic testing can affect different family members given the scenario. So like we said, we typically begin genetic testing with our patient who has HCM. So they are called our index case, and that's the box at the top. If they are found to have a pathogenic variant, or you may have heard it called a mutation, so basically that's a genetic change that has a known association to the disease. It's important to know that not all of our genetic changes are actually harmful. But if our index case does in fact have a harmful variant, it is then recommended that all biological family members pursue genetic testing themselves. If that relative is also positive, they would then establish care with a cardiologist, maybe even an HCM center of excellence if they can, and follow up screenings as they're recommended. If a relative in this case is negative, then they're considered a true negative, and that means we can rule them out. They do not need to undergo proactive screenings. Now, on the other hand, if our index case does not have a pathogenic variant identified on their genetic testing, then it is not advised that other family members pursue genetic testing themselves. However, especially for first-degree family members can still undergo baseline cardiovascular evaluations. And if they are first degree, they may be able to continue those evaluations, as we saw on a previous slide. For any of you who have familiarity with genetic testing, you may be aware that in addition to positive and negative, we can also get something called a variant of uncertain significance, or a VUS. A VUS is a genetic change that at the time that it's reported, there's not enough evidence to say whether the variant is pathogenic or benign. In these cases, it is really important for patients to continue following up with a genetic specialist or whoever their ordering provider was, because as data is collected over time, these classifications can change to positive or negative. And actually, even a classification that's originally listed as pathogenic or benign, with more evidence, can also change in rare cases. And for that reason, I do recommend that all of my patients follow up about every 2 to 5 years, just to make sure there's not been any updates. So to go back real quick, with our cardiovascular screenings and family members, the goal is to diagnose HCM at an earlier stage. With positive genetic testing or a first-degree relative, as we've heard earlier, HCM can actually be diagnosed at 13 millimeters rather than the traditional 15. And that provides more time and options for these individuals. Lastly, when working with families, it is common to have discussions about family planning, because of course, as we know, there's a lot of ways to create a family. But with positive genetic testing, it does open the door to options such as an IVF process with something called pre-implantation genetic diagnosis of embryos, or PGD. And that allows families, especially where they may see some more severe cases. We learned today that HCM is a spectrum disorder. It affects people differently, and it can also affect children and young adults quite severely. So some couples might decide that for them, they'd like to have a biological child, but not have risk of their child having the same mutation that they may have. And I'm going to let Dr. Azari share a case example of a family that she's worked with.
Thank you, Courtney. So here we have a family that I have seen and been working with. And over here on the right side of the screen, we have our pedigree, or our scientific family tree. All the women are shown by circles and all the men are in squares. And as you can see, there are multiple members of this family who were found to have a pathogenic or disease-causing mutation in the myosin binding protein C3 gene, and those are shown here in red. However, only 2 individuals were found to have clinical hypertrophic cardiomyopathy or ventricular tachycardia. And what this shows is that the power of genetics, who can identify individuals in this family who need to undergo regular cardiac evaluation, as well as those who do not. And it can really help them be diagnosed and treated earlier and prevent any arrhythmias and sudden death. And having this knowledge can motivate families to undergo genetic testing.
Oh, good job. So in addition to the typical factors of importance that we see associated with genetic testing in HCM, we also see greater motivations that might not be directly related to patient management. Oftentimes we see that the person who has HCM might not be pursuing genetic testing for themselves, but rather for their family members, namely children, grandchildren, those future generations. And I also frequently work with patients who are simply seeking answers, more from a psychological, psychosocial perspective, where they want to know, why did this happen to me? Why have I been diagnosed with this condition? And I will say this is most prominent in our younger patients as well as our adopted patients. And finally, we see that some of our patients, they may be pretty advanced in their disease. They may not have any living biological relatives, but yet they still want to pursue genetic testing for the sole purpose of advancing scientific knowledge. And in fact, one study published last year analyzed over 4,000 participants' attitudes towards genetic testing. And in total, 82% of those participants were willing to undergo genetic testing for improved treatment options. But still 73% reported that they were also willing to undergo testing for research and other altruistic reasons. So this supports the idea that these greater motivations are influencing many of our patients. And I will say that those statistics are pretty consistent with what I've seen in clinic with my HCM patients over the past few years. I would say between 85 and 95% of them are taking me up on testing when it's offered. Of course, with anything in healthcare, there are barriers. When it comes to genetic testing, there are unfortunately still quite a few, though there have been improvements. One, this is just a new field. And because of that, there's limited knowledge both within the healthcare setting as well as in the general population. So what we see is that the providers may not have the resources or the knowledge to pursue the testing for patients, and patients may not know what to be asking for of their providers. While there are genetics professionals to help providers and patients understand all of the benefits and limitations, there's limited access to these providers. And many patients who could benefit from genetic testing aren't going to have access to a genetics professional to help them interpret it. There are also, of course, challenges when it comes to things like cost and insurance, though we've seen great improvements recently. And finally, the conversation of genetics frequently brings up concerns about things like privacy and insurance discrimination, which we'll talk about these things a little bit further. So in terms of cost and insurance coverage, many private plans are now covering genetic testing, but of course, they all have their own kind of requirements. And you can see some examples here on the slide. They may require pretest counseling by a specific type of provider. They may require peer-to-peers or even preferred in-network labs. It is really important for the ordering provider to be aware of these stipulations in order to get the patients the best chance of coverage. Several genetic testing labs at this point do offer standard out-of-pocket costs for patients who do not want to go through insurance or they don't have insurance. And usually these are a few $100s per gene panel. Some labs might offer sponsored testing, which is of no cost, or even further patient assistance plans. And we are seeing free family cascade testing, which helps to encourage family members do that genetic testing. So what that means is that if a patient is found to have a pathogenic variant, some of the labs will offer for a certain time frame any biological family member, or at least first-degree relatives, to have genetic testing for that specific variant, kind of as a yes or no, for free. As we previously mentioned, patients do, rightfully so, have concerns about privacy. There's a lot of kind of preconceptions about genetics out there. And it's important to note that in 2008, the Genetic Information Non-Discrimination Act, called GINA, was signed into law. And GINA prohibits health insurance companies, as well as most employers, from discriminating based on genetic information. However, there are several limitations, and the law does not prevent discrimination from some of those advanced private policies, such as life insurance, long-term care insurance, or disability insurance. And this is something that should be discussed with all patients before they opt into the genetic testing. Of course, with our patients who already have a diagnosis of HCM themselves, this is going to be a little bit less important. Their medical diagnosis is probably going to take precedence for these types of things. But when we get to talking about those unaffected family members, it's crucial. And just for anyone's interest, there is a great fact sheet available. You can see through the U.S. Equal Employment Commission. It's pretty patient friendly. All right, so hopefully we've established that our patients are motivated to pursue testing. They want genetic testing, but it is crucial that we continue to improve access. And Actually, one study just published a few months ago reported that under 2% of our HCM patients are actually receiving genetic testing, despite the AHA-ACC guidelines suggesting that all patients with HCM should have genetic testing. And notably, most of these patients did have a family history of HCM. So just imagine how many patients we are missing and how many family members are not receiving the testing that they should be. So that's kind of one of our goals here with this initiative, is to compare and contrast how some of these successful clinics are able to integrate genetics and make sure that our patients are getting what they need. We have noticed in our conversation that we have a lot of similarities to work towards increasing genetic testing and decreasing those barriers. So our clinics tend to prioritize both pre and post-test genetic counseling for all patients, where we can address the benefits and limitations, the types of genetic test results, psychosocial concerns, and kind of any of those other questions that come up. We also both have found that it's important to prevent loss to follow-up by meeting patients where they're at. So similar to what we heard from the Utah team this morning, where they offer same-day appointments for several different specialties, I have worked with a clinic where we try to have an on-call genetics professional to be available on certain days so that patients can stop right on up, see a genetic counselor immediately following their cardiology visit while they're already at the hospital. That's not going to work for everyone, depending on patient and provider availability. So we also do try to use telehealth as much as possible. And I'll let Dr. Azari speak to her clinic as well. Thank you.
Well, thank you, Courtney. Yeah, we actually share a lot of the similar ways that we've tried to overcome some of these barriers. I see patients with a genetic counselor, and we provide the pre and post-test counseling at that time. We try to make ourselves available to see patients on some, but not all of the clinic days for our hypertrophic cardiomyopathy patients. For us, it's not possible to do all of the same day appointments, pretty much because the genetic counselor I work with also sees our pediatric patients on some of the other days. But we do have a significant telehealth practice. So about a third of our patients we see via telehealth, and this makes it easier for them as well. We also will do something where someone can pop into the clinic visit for the hypertrophic cardiomyopathy specialist, do a quick consent and pre-test counseling, have them go and go to the lab, and then see them via telehealth for the full appointment within a few days. And I think trying to be flexible in your approach to meeting patients where they are and taking a lot of these barriers out does make it a lot easier and for them to access genetic testing. Another thing that we also have found is that in providing patients with their results, doing their results visit, traditionally I had been taught where you speak to them in person and you hand them a piece of paper that has their genetic testing results. And then from there, sometimes we would also include a patient letter. So what we've expanded is to include a patient letter that also has the contact information for family members to contact. And we send it both in paper format, either mail or in person, and via email. And it's the email that we found helps a lot of our particularly younger patients because they can just forward it out to family members without having to do a difficult conversation, and it has our contact information right there. Now, we've come a very long way in the fields of genetics as well as hypertrophic cardiomyopathy. But where will genetics take us next? Well, as it was discussed a little bit earlier in the day, the next step will really be gene therapy. And it's not just science fiction, but only 5 months ago, the first patient was enrolled and began the step 1 or phase 1 of a clinical trial for genetically associated hypertrophic cardiomyopathy. Now, it is way too early to determine if this will be a viable therapy in the future, but it is an exciting first step. And to look back on how far we've come in the last 20, 30 years, I'm excited to see where we'll go. I would like to thank you for your time and attention and open it up for any questions.
Thank you, Courtney, and thank you, Dr. Azari, for that wonderful presentation. It does look like we have time for a few questions, and as a reminder to all of our attendees, you can put any questions in the chat. We did get a few questions in our registration process for this event. One of them was about, it asked, please discuss the causes in adolescent males. Is genetics a factor, and does this diagnosis correlate with hypertension? So I know a few items to untangle there, but maybe just discussing, the role of genetics in specifically adolescent males.
I can start. So for adolescent males, we know it's a time of a lot of activity as well as growth and changes. And for this group, they're monitored a little more frequently, at least imaging every year for them. As far as traditionally, if you look at studies for men, they tend to be diagnosed more commonly, as well as they have more ventricular events. Honestly, I'm not sure if it's just a genetic and gender component, or if it's also involved with us underdiagnosing women. But in this group, I do find that you need to be more concerned with working on those other modifiable risk factors. How about you, Courtney? What are your approaches to this group?
I would say very similarly. I work right now at an adult institution, so we're not working with many adolescents. We can't rule out, I think, with anyone, the genetic components, but of course, we always have to ask ourselves what those other factors are. And I do agree, I think women are underdiagnosed.
And then the next question, as you know, we have a really diverse audience in terms of healthcare professionals, and we also have many interested individuals, patients, and family members. So we got a question just asking about, how you work with your patients in sharing what the genetic testing recommendation, what the options are for genetic testing. And I know, Courtney, you talked about this a little bit, but anything that you'd like to add about, making those resources, that conversation accessible?
Yeah, I think definitely being flexible with patients, kind of, again, meeting them where they're at. Some patients come in, they have a lot of background on genetics. It could be very factual. Maybe they do have a scientific or healthcare background. Other patients, maybe they got their information from sources on the internet that may not be so factual. And so I think a lot of what I do at the beginning of my appointments is learning what the patient already knows, or what the patient's opinions of genetic testing is right from the start, so that we can try to address any either concerns up front, walk through what options might be best for them, really talk through those benefits and limitations. I do have patients where, like I said, they may be pretty advanced in their disease. The genetic testing at this point in time may not change anything for them, and maybe they don't have many living relatives that they're going to be sharing this with, and maybe in that case they decide that testing is not for them. I also think that we need to be available to patients kind of in the future. Like, it's not just a once and done. I've seen some patients 2 or 3 times because they're kind of on the edge. They want to think about it a little bit more. And sometimes they do come around after getting all of their questions answered.
Again, thank you so much to our speakers, Dr. Bani Azari and Courtney Hannum for this engaging presentation, and to our audience for your participation, your engagement. Coming up next at 2:15 Central, we have a conversation from a heart failing to a heart flourishing. To access that session, simply exit this one, return to the lobby, and click on that session. Thank you very much for attending today's HCM Connection Forum. We will see you shortly.